All right. Good morning, good morning. Top of the day to you. Actually, it's the afternoon. I don't even know what time it is anymore. Welcome, everyone, to the New York State Food as Medicine Planning Kickoff. My name is Natasha Pernica. I'm the Executive Director of the Food Pantries for the Capital District and one of the co-founders of the New York State Community Food Assistance Network. I want to welcome you to joining us today for this important meeting. We have over 200 people who are joining us today from across New York State, from so many different stakeholder groups. We have folks from our government, we have consumers of food as medicine programs, hospitals, health insurance, education. We have CBOs and food providers. We have people from a community and public health background, hospital systems, doctors, and more. I also want to give a special shout out to Assemblymember McDonald. I see you joined us today, so thank you so much for that. I want to just give a brief overview of what we're looking to accomplish today. We're in a Zoom format, so please keep yourself muted. If you're not speaking, feel free to have your camera on if you'd like. And if it's easier for you, you can use the speaker view so that the speaker is the one that pops up. But if you want to look at everyone, that's fine too. Food as medicine is important, and I believe that everyone here knows that food as medicine is an important intervention. I want to just start briefly by mentioning it's a little bit older Health Affairs article, but I think it's very important for us to recognize. In 2017, the US spent $3.5 trillion on health care, and one of the most important determinants of health is balanced nutrition. Proper nutrition is necessary to heal wounds, control chronic illnesses, and build or maintain our strength. Malnutrition, we talk a lot about food insecurity, but really malnutrition is an important component as well. And it's an under-recognized health issue that results in substantial disease and economic burden, as well as elevated mortality rates. According to this Health Affairs article, up to 50% of hospitalized patients in the United States are either malnourished or at risk of malnutrition, but only 8% receive a medical diagnosis of malnutrition during their hospital stay. So we know that nutrition is important to recovering from illness and prevention as well. One of the keys to maintaining proper nutrition is that connection from hospitals and primary care and community health settings to proper nutrition and nutrition education to help someone's health in the long term. So we know what we're calling as either food as medicine or food is medicine interventions change lives, from veggie prescription and food pharmacies to medically tailored meals and groceries and more. We are coming together today to develop a community-informed food as medicine plan for New York State that integrates medically tailored food and nutrition services into the state's Medicaid program with a goal to improve health and reduce healthcare costs. So talking through our day today, we have a really great panel. I want to thank everyone who's participating as speakers. We'll first hear from a program participant, Tammy Holmes, followed by a panel that's going to have an overview of the different types of Medicaid funding strategies. We're going to hear about how California has implemented a continuum of care model in the state of California, and then we'll hear specifically where New York State is at with this. Our next panel will have 3 different New York State providers that have different types of program models. And then we'll take a quick stretch break. We hope everyone will continue to stay on for our second part of the program. Because this is a community-informed process, this is our chance to get your feedback. This is our first step, really, in creating our planning process to create policies and program models and funding streams that work here in New York State for everyone. So our first breakout room will be facilitated. We'll be asking for your input about the different program models, about what you're currently doing, what you think works, what's missing, what needs to be included here in New York State. Our second conversation then will be about funding structures. Whatever we put together here in New York State, we want to make sure that it works for all of the stakeholder groups that are involved in the system and the care, as well as the participants themselves. And then we'll be ending with our next steps. We'll have a brief conversation about the White House Conference on Hunger, Nutrition, and Health, and what our next steps are through the New York State Community Food Assistance Network to keep this going. So again, thank you so much for joining us today. So now I'm going to invite Tammy Holmes to share her experience as a food as medicine provider and really talk about the impact that it's had in her lives. Tammy, I'm going to give it to you now.
Thank you. Hello, everyone. I am Tammy Holmes, and I am very honored to be here today and share to you and show proof positive what this program can do. I am 52 years old. I am pretty much 80% blind. I'm in a wheelchair. I have diabetes and heart disease. Years ago, while I was raising my children, I did not have health care and proper nutrition. And one day I got sick, and next thing I know, I had heart disease and my diabetes had really ramped up and I got sick. And through the course of time, my health deteriorated. Being a single mom and now raising 2 grandchildren, it was very difficult. I had to make some very difficult decisions. The children needed shoes, we needed food, we have living. It was impossible some months. Now I had, through my insurance agency, shout out to CDPHP. They got me involved. My facilitator got me involved with this. And let me tell you how this works. I was given a nutritionist, someone that actually sat down with me and explained what foods are good, what's bad, why I need a diabetic cardiac diet, why I have to have a kidney diet, and we make it work. We make sure on a bi-weekly basis that the foods that I need to have and don't need to have as much of, we pick it out. It's not like the government sends me food and says, eat it. I shop at a local grocery store and I pick up or they deliver my food. I have learned so much. I actually started saying that this program should be called Health because it's healthier eating to achieve long-term health. And that's what it is. And it's hope. It's not just, here's a bag of groceries. I was at the point where I had gained so much weight because of improper nutrition. I'm anemic. My blood levels were very low, and I was taking $4,500 a month in nothing but insulin because I was so insulin resistant. I had gained up to 380 pounds from eating processed foods like ramen noodles and bread, the cheapest things that I could afford. All while keep in mind, I'm raising 2 grandchildren who are now 15 and 8. And I had to make choices. Then the program came along. In the sight of the last 6 months, I am down 40% in insulin. I did the math. My insulin's at $4,000 a month. It's now down. I have saved a total every month from the insurance companies. I have saved a total of $1,053 a month because I don't need as much insulin as I was on because I'm eating better, because I have the opportunity to have whole grains and protein and what needs to be eaten instead of a ramen noodle or SpaghettiOs. I have had 0 hospitalizations in the past year, where I was always at least a couple a year going in for an infection or my kidneys or something. I've had 0 hospitalizations. I have, my grandchildren have became so much healthier because we now have someone that helps us strategize with the food, how to use it, what to do, how to sneak vegetables into a child. And we've become very creative with it, and it has worked. It has worked. The hope in the healing and saving 1,483. I'm sorry, let me rephrase that. For both insulins a month, I've cut back 40%. And they give me a $100 bag of groceries every 2 weeks. Do the math. I take less blood pressure medication. I take less insulin. I don't need, as even down to my CPAP, my apnea has gotten so much better. It's hope. Where I was at the point that I was ready to give up and say, you know, that next infection, if I die, okay, I'll make sure my kids have somebody to take care of them, because I'm mama to them. And I know there are a lot of grandparents and aunts and uncles out there raising children that are not biologically theirs, but I would kind of like to be here for the long haul. I've lost 44 pounds. 44 pounds. All because someone cared enough about me and to give me hope in the proper food and the proper usage and knowledge of how and what. Who knew potassium was in cantaloupe? I mean, just the things that I need to stay away from. And I don't, and celery contains salt. But Nicole, my nutritionist, is fabulous with this. This program could not only, and I get it's about money. I get it's about saving the government money. I'm all for saving money. I have to save money. I'm a big couponer. But I know, but if you can take a life and treat the ounce of prevention to make that pound of cure, it's a no-brainer. It's a no-brainer. I'm blind in a wheelchair. I can't get up and walk. I can't get up and exercise because I had 2 strokes. But I've lost 44 pounds. And I have felt better in the past 6 months than I ever thought I ever could, because I had proper nutrition. My blood levels are good. My kidney function has improved to where my doctor now says I can live indefinitely on my function. Indefinitely. Do you know what that means to a grandmother who's raising autistic children that need help, will probably need help long-term, one of them his whole life? It's hope. It's hope where I had no hope. This program I am very passionate about. And it makes sense. If you teach a man to fish, he'll eat for a lifetime. So with the proper food as medicine program, with the nutritionists, and with the little bit, that $200 a month is saving over 14 in insulin alone. And you can call any pharmacy. I'm on Tresiba and Humulin U200. I'm taking 40% less than what I was. I was on over 400 units a day. But now I literally take 160. And then what I eat, I bolus. I mean, it's all about being able to put that money towards other things in healthcare. I'm not having to go to the doctor. I'm doing my regular checkups. It's a no-brainer. This is very important. We
Tammy,
really need to get this out there.
I want to share with you, Tammy, some of the chats. People are saying, thank you, Tammy, for sharing your extremely important story. Congratulations to you. Outstanding. Congratulations to you for all the positive changes you have made. What a testimony. And Ms. Holmes, thank you for sharing your story. So inspiring. It really is a no-brainer. Tammy, You are a remarkable person and
Thank
grateful
you.
for you to spend your time sharing the impact that this has made in your health and in your life. And we're going to move on to say, how do we do this for you and continue to do this for even more and more people throughout the state of New York? So thank you, Tammy.
Thank
Giving
you.
you a round of applause like we're in a big
Thank
audience.
you very much.
Thank you. So I'm going to move on to, and this is just incredible. This is why we're all passionate about the work and the possibility for food as medicine interventions. I'm going to kick it over now to our Food as Medicine Medicaid overview panel. We're going to start today with Katie Garfield from the Center for Health Law and Policy Innovation of Harvard Law School. She's going to give an overview about the Medicaid payment pathways for food as medicine or food is medicine interventions. It's all you, Katie.
Excellent. Thank you, Natasha. And thank you, Tammy, so much for sharing your story. It's a tough act to follow, but I will do my best. So thank you all for having me here today. I'll be kicking things off by providing a high-level overview of the current status of food as medicine interventions in the Medicaid program. I'll then be handing things over to my fellow panelists to talk more about how these opportunities are playing out on the ground in some individual states. So let's start by, next slide. Let's start by stepping back and looking at the status of food as medicine services in the US healthcare system as a whole. We'll then zoom in on Medicaid specifically. If we think of the US healthcare system as a house, our key takeaway is that food as medicine services aren't really going through that front door. And what I mean by that is that food as medicine services are not generally part of baseline covered benefits in our healthcare programs. They are not being built into standard coverage and payment systems the way things like prescription medications and doctor's visits would be. However, that's not to say they aren't making it into the healthcare system at all. Instead, we think of them as sort of coming in through the windows. Food as medicine services are making it into the healthcare system through narrower opportunities such as Medicaid waivers and flexibilities available to individual plans in our Medicaid and Medicare systems. Ultimately, I think we do need to move away from this sort of window system. By limiting food as medicine to these windows, we're creating a patchwork of coverage where access depends on your zip code, form of health insurance, and individual plan. If we can achieve policy change at a broader national level to build coverage of food as medicine services into baseline benefits, we're going to end up with a much more equitable system. But that's not where we are now. And so in the meantime, food as medicine advocates can work to maximize these windows to gradually scale and sustain food as medicine services in their states. Next slide. So what do these windows of opportunity look like in the Medicaid program specifically? Well, they fall primarily into the 4 categories we've outlined here. First, there are a number of different authorities that allow Medicaid programs to cover home and community-based services or non-traditional services to keep individuals in the community that would otherwise need an institutional level of care. And many states use home and community-based services waivers and state plan amendments to provide home delivered meals to certain high need populations. Next, there are Medicaid Section 1115 demonstration waivers. These are 5-year waivers that states can request from CMS in order to test new models of payment and healthcare delivery for their Medicaid enrollees. And a growing number of states, including North Carolina, Massachusetts, Oregon, and others, are using 1115 waivers to experiment with paying for food as medicine services. Third, there are Medicaid managed care flexibilities. Managed care plans are health plans that contract with your state Medicaid agency to deliver Medicaid services. While these plans must generally cover baseline services included in the Medicaid state plan, federal regulations also give them other authorities to cover extra services. And those extra pathways are sort of outlined in this slide. They include things like value-added services, which are extra services the plan can provide, but doesn't really get paid for independently by the state. Then we have in lieu of services, or services that the plan provides as medically appropriate, cost-effective substitutes for state plan services, and which can be paid for in the capitation rate for the plan. And then we have value-based payment models. these are sort of changes to the way the plan pays its network of providers. And these changes may create new flexibilities to include food as medicine providers in payment and care delivery. Notably, California is currently making a big push around in lieu of services for food as medicine services that I think we'll hear a bit about. And New York also has in lieu of services and has a particularly detailed focus and creative approach to value-based payment as well. And then finally, I'll just note there are also state-funded pilots. These are pilots created and paid for through state legislation or appropriation to experiment with the delivery of food as medicine services to Medicaid enrollees. An example of this has occurred in California, again, which I think we'll hear about a bit later. Next slide. I will note that most, if not all, of these pathways are already happening in New York. And so in many ways, your state is ahead of the game. These next two slides are just to provide some brief considerations as you think about the best ways to weave food as medicine services into the work that's being done on the ground in New York. First, I want to highlight that the key decision maker for food as medicine payment really varies by pathway. So if you're looking to pursue a waiver pathway, your key decision maker is going to be your Medicaid agency, who would need to request the waiver or amendment from CMS. In contrast, both state Medicaid agencies and individual health plans play an important role in the Medicaid managed care pathways. For example, if trying to cover food as medicine services as an in lieu of service, that cost-effective substitute, the state must approve the food as medicine service as an in lieu of service, and then individual plans have the option to cover them. Similarly, the state can set value-based payment requirements in managed care contracts, and then individual plans have some discretion in how those are implemented. And of course, state pilots established by legislation would have the legislature as their key decision makers. Next slide. Next slide. Oh, there we go. Finally, I just want to note that there are pros and cons to each of these pathways, with some of the pathways working more or less well for different stakeholders in the state. For example, in many ways, 1115 waivers are an excellent pathway for patients and food as medicine providers. They're highly flexible, allowing the state to reach a wide variety of enrollees rather than just managed care enrollees, and cover a wide variety of food as medicine services. However, they have to be cost neutral, renewed every 5 years, with a lengthy application and evaluation process. In contrast, in lieu of services might be particularly appealing for plans. Unlike some of the other managed care pathways, the costs of in lieu of services can be built into capitation payment rates that plans receive from the state. It's also up to the plans to decide whether or not to cover those services. However, of course, in lieu of services may not reach all Medicaid patients as they're limited to managed care and the individual plans who choose to cover them. And then finally, if we're thinking about value-based payment requirements, they can be highly appealing to plans in the state. They can be used to promote innovative contracting models between plans and providers that may make room for delivery of non-traditional services. However, the one note I would say here is that food as medicine providers need to be proactive in helping to shape those models with plans, healthcare providers, and potentially the state. Otherwise, you may end up with models that don't work as well for food as medicine providers as you would like. For example, perhaps promoting just referrals, but not payment for services, or using inadequate rates or unreliable payment structures, or perhaps putting an amount of risk on CBOs that community-based organizations are unprepared to handle. So while value-based payment creates really valuable opportunities, just noting that being in the room and helping to shape them is important. And so with that sort of food for thought, I think I'm going to now pass things along to my fellow panelists to talk about how some of these opportunities are playing out in California and New York.
Thank you so much, Katie. And we will be pulling these slides up when we have our conversation in the breakout rooms for reference as well. So thank you. This was incredibly useful information for this conversation. Now I'm going to invite Joseph Billingsley from the California Department of Healthcare Services to talk a little bit about how California is implementing this. Thank you. Where's Joseph? Oh, there you are. We got to unmute you.
Am I unmuted now?
Yep, you're unmuted.
Perfect. Good morning, everybody. Again, I am Joseph Billingsley with the California Department of Healthcare Services and the Assistant Deputy Director for Integrated Systems of Care within our department. And basically that means I have responsibility for our various 1915C, HCBS waivers, a lot of various carve-out programs, providing carved-out services for our Medicaid population in California. And so today specifically, I want to talk about a pilot program that we have just ended and that really worked to inform also new in lieu of services, or as we call them, community supports that we've included in our managed care models in California. So just seeing how to advance the slides when I'm in screen share. Sorry, the difficulty. Okay, here we go. So just to start off, I wanted to give a quick background on our the Medically Covered Meals pilot program that we initiated in California back in April of 2018. This pilot program was really a grassroots effort in California by various stakeholder groups, including our Food is Medicine Coalition in California and Project Open Hand. And the purpose was to replicate smaller, more localized pilot programs that have been done within specific communities, like our San Francisco, City and County of San Francisco, and working with specific hospitals or health plans, and really to look to replicate that on a larger scale and look at how medically tailored meals might be evaluated as a benefit for our Medi-Cal population. And Medi-Cal is what we refer to Medicaid as in California. And so it was authorized as a 3-year pilot. It launched in April of 2018. We did end up extending it an extra year. The pilot actually just concluded in March of this year to ensure that we had sufficient time to serve all beneficiaries. Basically the pilot was, because we wanted to ensure that we were able to do a robust evaluation of the pilot, we did make the pilots for a specific population, tailoring it to be available to Medi-Cal beneficiaries that had a diagnosis of congestive heart failure. The pilot was available in 8 counties throughout California. This included a mix of large counties, like larger urban counties like San Francisco, Los Angeles, San Diego, Alameda, and Santa Clara, as well as some more rural counties. And the pilot was intended to serve 1,413 individuals over the course of the pilot program. The way the pilot worked was we would work to, there was a referral process for identifying the different organizations that were providing pilot services. Would work with local health plans and hospitals to identify individuals that were being discharged back to the home and that would had a qualifying condition of congestive heart failure. And then they would work with the department to verify that those individuals were Medi-Cal beneficiaries meeting the criteria for the pilot program. If those individuals agreed to participate in the pilot program, it would be a 12-week program where they would have 3 meals per day delivered during that program. And those meals, they would work with nutritionists, design those meals to meet their specific needs in working to recover from the issues that had landed them in the hospital, and really work to stabilize their diet and also help to establish a program for continued diet stabilization following completion of the actual NTM pilot intervention. So during the process, there would be, wellness checks done during the meal delivery. They also had 4 sessions throughout the pilot program with a nutritionist to, again, address their individual nutritional needs, and also received case management during the program that included referrals to community resources for continued assistance following the pilot program. From an evaluation standpoint, we really designed the pilot program and the evaluation that is now ongoing to be able to determine the causal impacts of the MTM program on healthcare use and health outcomes for beneficiaries with congestive heart failure. Looking at answering the questions, can the medically tailored meals improve health outcomes and reduce healthcare expenditures for beneficiaries with congestive heart failure? And with the goal of reducing the use of high-cost acute and post-acute care services, including emergency department visits, inpatient stays, and skilled nursing facility stays. Some specific preliminary data that we can provide, because the evaluation, again, we did extend the pilot through March of this year. The final evaluation is due December of this year, and then will be released publicly, including to our legislature in April of next year. So in April of next year, you will be able to go to the Department of Healthcare Services website and access that evaluation. So just to identify some preliminary findings, the pilot program ended up serving, almost completing its goal of serving 1,400 beneficiaries. We enrolled 1,168 unique participants in the program. 720 completed the full 12-week intervention. An additional 381 completed a portion of the intervention, but dropped before completing the full 12 weeks. And during the course of the pilot program, 215,045 meals were delivered to individuals in their homes. And again, preliminary results indicated reduced utilization of high-cost acute and post-acute services through the treatment of beneficiaries following engagement with the pilot program. Now for my final slide, and this is really the more exciting part for me, is getting to talk about the impact that that initial pilot program has had. And even though, again, we have not, we just completed the pilot program, the evaluation is still underway. What it really played a big role in was helping to inform design and development of our California Advancing and Innovating Medi-Cal initiative. This is our new, it's basically a combination of California's new, our 1115 waiver renewal as well, which included as part of that, shifting the authority for our managed care delivery system from the 1115 demonstration waiver over to a 1915B. But basically, the overall goals of CalAIM, as we refer to it, is really transforming the Medi-Cal delivery system, looking to eliminate duplication and really work to streamline how beneficiaries in California access their care, and not just looking at addressing their medical care, but really looking at addressing the whole person care, and also looking at addressing social drivers of health. And so part of that process, I think, it was good timing with that pilot program going on. That pilot program, you also saw replication of that across multiple managed care plans in California, where we had managed care plans that were doing their own smaller, focused pilots, whether it be with medically tailored meals or medically supported food, testing those things out at that time. And so while we were working on developing our CalAIM initiative, which was originally supposed to launch in 2021, but was delayed by the COVID-19 public health emergency, it really provided for a chance for an informed stakeholder process to hear from stakeholders around the value of medically tailored meals and medically supported food as medicine. So looking at preliminary results that we were seeing from the pilot, hearing from stakeholders That is actually something that California chose to include within its CalAIM initiative, including medically tailored meals and medically supportive food as one of our in lieu of services, or again, as we speak to it in California, we refer to them as community supports. Those became available in January of this year, January 2022, when our CalAIM initiative launched. Now, managed care plans have the option of choosing to make those available, so they're not required to make them available. But we're very happy to say that a majority of our managed care plans in California have chosen to elect to make the medically tailored meals and supportive food community support option available. And really, that expands on the more narrow medically tailored meals pilot program that we did, and really having a broad definition for that community support, which includes meals delivered to the home following a discharge from the hospital or nursing facility. That can include medically tailored meals. It can include medically supportive food. It can include providing nutritional counseling, working to provide, again, a variety of issues, whether somebody needs food delivered or whether they're going to go to the store and shop for food based upon a diet that they've worked with, their support system to develop. There's a real wide range of criteria that we've made available for this community support option within our CalAIM initiative. So really happy to see how California has progressed from the initial pilot program to really expanding how we're making food as medicine available for our beneficiaries. And I'll go ahead and end there. I've left my contact information here, but look forward to participating in the rest of this process, and I'll hand off to the next presenter. Thank you all.
Thank you. Thank you so much, Joseph. You had a lot of great information. And as we don't have a lot of time for questions, I do want to just mention to those of you who are on the meeting, if you feel free to put questions in the chat, and our panelists and speakers can take a look in the chat and see if there's any questions in relation to their part of the presentation. So thanks again, Joseph. And so now I'm excited to introduce Emily Engel from the New York State Department of Health to talk about where are we right now in New York State currently, and where they're looking at going. Emily?
Hi, everyone. I'm so happy to be here to talk about what we've been doing in food security in the Medicaid program. It's been an exciting space, and we've had a lot of progress, so I'm excited to share that with you today. Let me just share my screen. Okay, can you guys see that okay? Okay, great. So I'm going to talk about value-based payment. Katie in her overview was mentioning that you can do, make value-based payment requirements related to food security, and that is something that we did. And we also have a medically tailored meal in lieu of service project that we've done. So I want to talk about both of those. And then I don't have it on the agenda, but we have an 1115 waiver that we're getting ready to submit that also ties into this. It's really exciting. So under value-based payment, we required managed care organizations to have at least one social determinant of health intervention and contract with at least one community-based organization. And from that, we saw food security as a really big focus that plans contracted for. And we didn't say, what they had to focus in. We left it to, it just had to be a social determinant of health intervention, look at your data, talk to your VBP contractors, to really determine the need. And not surprising, food security was one of those big needs. Under food security, though, we saw medically tailored meals. We saw connection to community food resources, nutritional counseling, mobile food pantries, telehealth and transportation for high-risk diabetics, We had farmer market vouchers, food pharmacies. So it's really an exciting space in VBP. There was a lot of creativity. And we thought, medically tailored meals was one of the larger chosen interventions, and how can we expand upon that? So we started under MRT2. We got the ability to create 3 different types of pilots, and one of those was medically tailored meals. And so the medically tailored meals are targeted to 18 years and older, living with a severe illness through a referral of a medical professional or healthcare plan. The meal plans are tailored to the medical needs of the recipient by a registered dietitian nurse, nutritionist, and designed to improve health outcomes, lower cost of care, and increase, of course, patient satisfaction. So we decided to do this through an in lieu of service so that we didn't have to limit the geography and scope of the project. So we did a state identified in lieu of service, and any plan can opt in to the in lieu of service and provide it to any members that meet the criteria. So our criteria, we have 2 different buckets. It can be individuals who receive personal care aid services that receive meal prep and food shopping. Those hours can be decreased, and instead they would receive a medically tailored meal. The medically tailored meals, I don't think I mentioned, are in 6-month increments, and the plan can keep renewing that as needed. And then the second bucket is to prevent hospital inpatient stays, emergency department visits. So we know, if you have a history of inpatient stays or emergency department visits related to cancer, diabetes, heart failure, HIV, AIDS, that could very most likely will happen again, right? And so instead of paying for the next ED visit or the next inpatient visit, let's pay for medically tailored meals. It's a much more cost-effective solution. It makes sense. And so plans can look at the history of the Medicaid members within their the plan and say, okay, this person has a history of emergency department visits. Let's get them into a medically tailored meal program and contract with a community-based organization to then provide that medically tailored meal. This is a new in lieu of service. It started, I think our first set of plans started on April 1st, and the second batch started on July 1st. We have 6 major plans in New York State signed up so far. And we're really excited about working with plans to grow that even more. And then, as I mentioned, I don't have a slide for the waiver, but we are right now finishing up our public comment. We received public comment on our 1115 waiver, and we're hopefully submitting that to CMS very soon in the near future. And part of that waiver, obviously, it was focused strongly on health equity and breaking down the silos, right, between social care and healthcare, because they really do go together. And so long we've looked at them as separate, issues for a member, but they really belong together. And so the waiver would create social determinant of health networks composed of community-based organizations that address social needs and screen members for things like food security. And then if someone is screened as needing assistance with food security, then giving a referral to a community-based organization and paying for that referral to help that individual. So it's really exciting to have that 1115 in the pipeline. And like I said, hopefully we'll be, submitting that soon to CMS.
Great. Thank you so much, Emily. It's really great to see where New York State is at this point, and looking forward to bringing stakeholder input together to you and New York State as we continue to develop a more comprehensive program moving forward. So thank you. So we're going to shift again. If you do have questions, feel free to put them in the chat and we'll have our panelists take a look to see if there's anything coming through. Now we're going to shift to talk a little bit about the different programs themselves and the models here in New York State. There's a lot of conversation and funding streams for the medically tailored prepared meals right now, but there are other different kind of models of food as medicine interventions. So we'd like to start today by inviting Camille Verbofsky from FoodLink, which is the food bank in Rochester, to talk about their food as medicine program. Camille?
Thank you so much. I'm just going to share my slides here. All right, there we go. We're loaded. Thank you so much. My name is Camille Verbofsky. I'm the Director of Community Health Programs at FoodLink. We're the regional Feeding America food bank for Rochester, New York. So grateful to be here today to talk about our fruit and vegetable prescription program through our curbside market. So FoodLink, we're the regional food bank for Rochester and the 10-county Finger Lakes region. Our mission is to leverage the power of food to end hunger and build healthier communities. And in addition to what you might think of as more traditional food banking, we live out our mission through a number of mid and upstream programs like our curbside market, which is FoodLink's mobile market program. Currently, we visit 50 sites a week in areas where our neighbors experience limited food access. We make it easier for folks to shop for healthy choices for themselves and their families and believe that everyone deserves access to fresh foods. We sell fresh produce and select grocery items and accept cash, credit, SNAP, FMNP. Over the past few years, we're one of the longest running double up food box vendors in the state. And we've recently expanded, become the first mobile WIC vendor in the nation. Through our healthcare partnerships, we're working on an expanded home delivery program as well. So how does our food prescription at curbside market work? We received funding in 2018 to overhaul our curbside market point of sale system so that we could match redemption data at the market to participant health outcomes data. And we also developed a simple online enrollment portal where providers and payers can enroll participants directly into the program. Of course, the goal for all of this is to make it easy for our healthcare partners to meet the quadruple aim. So how does it work? Right now, our most successful and longstanding program is with Excelis Blue Cross Blue Shield. As payers, they use claims data to identify members that meet different inclusion criteria based on whatever they're interested in targeting. And then the members are engaged by Excelis's care management teams who conduct outreach over the phone to enroll members. And they also do ongoing surveys and check-ins to see if people are using the service. Fresh account is prescribed. The members are enrolled in Curbside Market RX portal and they get their card, their Fresh Account card in the mail, along with some other information about what we offer, how to shop, and everything like that. It's redeemed. Participants use their card, which has $30 a month loaded onto it on the first of the month. It expires at the end of the month, and they can shop for anything on Curbside Market. And the redemption and health data are then matched. Relevant claims data are matched by the participant ID, and those data are analyzed by our partners at Excelis and some of their vendors, one called Algorex. So it's nice as a CBO, it keeps us out of really housing any healthcare data. So how did this program get started? Right now in 2018, we really launched the program. In 2020, we really solidified it with our partnership with Excelis. But since Curbside started in 2013, we've had providers and healthcare systems reaching out to us and saying, hey, how can we connect our patients to this access points for healthy food? And for the first 5 years, that was a paper coupon that we tracked on an Excel spreadsheet and then gave back to the providers to see what we could do with it. By 2018, we had enough people that were interested in that we felt that this could really be successful. And through funding from FLIPS, our local DISRIP office, we were able to overhaul our system to do this. And by 2019 of July, we were able to use that funding to partner with GRIPA. They're the accountable care organization for Rochester Regional Health System here in Rochester. We work specifically with a program called Healthy Moms, which is a change management prenatal and postnatal program, as well as people that were enrolled in working with community health workers. For April, and then in April of March of 2020, of course, COVID happened and we had to close the market. And we had people call us and say, hey, we were really relying on this program, especially for our kids. What can you do? We really would love this. And we knew we had to try home delivery. So within a month, with support from FLIPS and from GRIPA, we were able to launch our first home delivery program for 90 participants. They received bi-weekly deliveries through December. And at the end of that program, it was kind of a rough ending. It was a really question of like, who's going to pay to sustain this? And it was hard for the ACOs to take on that added cost at the time with everything going on with COVID. And in the meantime, we were working with Excelis on what started off, or what kicked off in August of 2020 as our first fee-for-service healthcare program. So Excelis paid us directly. 250 people were each enrolled in a 6-month campaign. So we had 500 people total to start. We've done 3 campaigns so far, each of 250. And Excelis pays us each month for the people that redeem. They've really, really invested in their internal systems to track data, to change their workflows for their call teams to make sure that people are enrolled. So they've just been an incredible partner, which led us to March of this year, where we launched, we went back to our home delivery program, and with funding from FLIPS and in partnership from Excelis, we're doing a home delivery program for 150 folks that are pregnant in Monroe and Ontario counties. They receive that same delivery of about $15 worth of produce every other week for a year. We hope to match that to birth outcomes, maternal health outcomes, as well as cost saving measures, and are really excited about the future of that for our food as medicine work. We've got some really great preliminary data. Of course, claims data takes a really long time to get and match after an intervention like this. In our first campaign of 250 people, we're starting to see some positive results. Overwhelming majority of market users said that the program has helped their family and that it made them feel very supported by Excelis. We saw an increase in the number of folks that reported food insecurity using food insecurity measures. And that 19 to 33%, that first cohort took place really in the peak of COVID. So to see those numbers increase during COVID, to me, is really positive. We're really excited to share that we've been able to see a statistically significant impact on the total cost of care and hospital outpatient visits, which we're excited to say has yielded a positive ROI for the program. Hope to sustain. I'm probably over my time. Just want to say thanks to FLIPS, Excelis, Algorex, GRIPA, and our partners at Healthy Moms for making this possible. Teamwork makes the dream work.
Great. Thank you so much, Camille. It's really great to see your example of a model and what you guys have been able to accomplish. It's really great. So that's one model of food as medicine intervention. Now I'm going to kick it over to Alyssa Wasung from God's Love We Deliver in New York City to talk about their model.
Awesome. Thank you so much, Natasha, and everybody who has organized this amazing convening. I just want to make sure you're all seeing the right end and not the back end of my slides.
Looks good.
Awesome. So I know that we've heard quite a bit about medically tailored meals, and I just want to talk about the intervention itself. And I just want to say thank you, Camille, and my fellow presenters for your inspiring programs. I always learn so much on these gatherings. So God's Love We Deliver is a medically tailored meal provider in New York City. We are non-sectarian and nonprofit and have been around for many years, even though I think that there's been a lot of focus on the medically tailored meal intervention in recent years. It is an intervention that has existed and changed the lives of our clients for many, many years. So I want to start first with, of course, our mission. Mission is so important to us, and our clients are so important to us. God's Love got our start over 35 years ago, like at the height of the AIDS pandemic. And we were delivering then meals to people who were dying of AIDS. And our meals at that time were really designed to help people be as healthy as they could be for as long as possible. When the trajectory of the HIV epidemic changed by the introduction of medication, our program changed, but we were always focused on nutrition and on the needs and the health of our clients. Early on, we added registered dietitian nutritionists to our program. And since then, we've been very focused on the nutrition science that is ever evolving and is really a focus of our program and our services to clients. Today, what our program looks like is that we've expanded our mission, and we now serve people living with over 200 different severe and chronic illnesses, from HIV to cancer to cardiovascular disease, Parkinson's, MS, ALS, difficult renal disease cases, people who are living with multiple diagnoses. And we serve not only the client, but recognize that when someone is sick, it affects the whole family structure. So we serve the caregivers and the children of our clients as well to support the family structure. What this translates to today is service to all 8 downstate counties, as well as some of the counties as we go north into the Hudson and parts of New Jersey. And that translates to about 2.6 million meals a year to about 10,000 people. We do all of this work with the incredible participation of our community to the tune of about 17,000 volunteers a year. And they really are the heart and soul of God's love and are the love in our name. So moving on to our clients, because it really is about the people that we serve. God's love is really addressing nutrition through the lens of illness. That is where we fall on the pyramid or the continuum, or however you organize food as medicine interventions. God's Love and our sister agencies across the country in the Food as Medicine Coalition recognize that we are not the only food as medicine intervention, but one in a continuum. And where we focus is on the sickest of the sick in our communities, people who are living with usually more than one illness. So on the left-hand side here, you have a pie graph that shows the primary diagnoses of our clients. But on the right, you can see that almost 90% of our clients live with one or more conditions, and 40% are living with 5 or more. So this is a very critically ill population that has complicated medical diagnoses that result in challenges obtaining the right nutrition for their diagnosis. Today, as I said, we serve about 10,000 people. That includes clients, children, and the caregivers that I mentioned. And the way someone becomes eligible for our program is that they have a chronic health diagnosis and activities of daily living limitations. So what is the intervention? People talk about medically tailored meals all the time, and many people are familiar with home delivered meals. Medically tailored meals are a little different. We think of it more as an intervention rather than the meal itself, and there are many different components of it. First, our meals are designed by our registered dietitians. We have a team of 8 on staff, and our executive chef and our other chefs, to be as delicious and nutritious and full of variety as possible. Our menus are designed so that any cultural or ethnic group that's looking at our menu will see themselves in our menu. And we design our meal plans based on a restriction basis. So our goal is that someone gets the most variety possible given their complicated medical situation. Because one of the first things to go when someone is sick is appetite. And we want our clients to eat the food that we're sending them. So on the right, that really colorful wheel is an example of how our dietitians modify our meals so that someone is getting the most delicious variety. Over on the left is the official definition of medically tailored meals through the Food as Medicine Coalition. And if you're interested in the nutrition evidence behind our model, you can find it at the link on the left-hand side. And yes, the slides will be available. Something to remember is that our meals are made from scratch, which is important to us and important to the nutritional value of our meals. They are made without starters, fillers, or preservatives, flash frozen and delivered to our clients in refrigerated vans all over our delivery area. And then my favorite part of the food as medicine side of medically tailored meals is that is what our executive chef says about them. Our food is medicine, but it doesn't have to taste like it. So a little bit more about the intervention. As I said, it's many different parts that come together to make a complete intervention where our clients feel supported. The way someone comes onto our program is we have a no wrong door entry referral system. Clients can be referred by anyone in the community. They can call their mother, brother, sister, second cousin, twice removed can call. Their doctor can facilitate an introduction, their health plan. We accept people from all over our community. Once they come into the God's Love system, they then have to have their diagnosis and need for meals confirmed by medical professionals. They go through an in-depth one-on-one nutrition assessment with an RDN on staff, and that's how their meal plan is formulated. Then, as I said, we cook it fresh in our kitchen in New York City, blast chill it, flash freeze it, and out it goes to their homes. And they enjoy this delicious meal program. And we'll talk a little bit about what that means for outcomes in a moment. To us, nutrition counseling and education is key. Clients can call in at any time and get a free consultation with their RDN, change their menu or their diet, maybe based on treatment or new medications, so they feel supported throughout. And of course, as a nonprofit in the community, we like to put a lot of love into our program. So clients enjoy special touches like birthday cakes and cards at the holidays and special holiday meal deliveries. So I want to talk a little bit about the evidence. Receipt of medically tailored meals has been talked about a lot. This is only a few of some of the stats that have come out recently from peer-reviewed journals, and more is coming out every day. As I said, God's Love leads the Food as Medicine Coalition nationally, and we're all collectively working to improve the data because we all believe food is medicine, but we have to have the data to show decision makers that it is. And I want to point out that God's Love can feed someone medically tailored meals for 1 year for the average cost of one stay in the hospital. And so before I turn it back over, because I think we're all going a little over on our time because we love our programs and there's so much to talk about, I just want to say, despite this research and despite all you're hearing about healthcare innovation, God's Love and most of our peer agencies across the country are not funded by any dedicated federal funding stream, not SNAP, not WIC, not OAA in any specific or fundamental way. The only federal funding stream that funds our meals specifically is the Ryan White HIV/AIDS program. And that only funds meals for people with HIV and doesn't cover all the people with HIV that come to us in need. So God's Love is raising the majority of its budget every year from our community to do our work. And how we are trying to make accessibility a reality for our clients and for all the people in New York State and across the country who we know need this service is working through policy. So you heard a bit from Katie about how Medicaid has come to support food as medicine interventions. This is just sort of a bar graph of how we have tried to take advantage of some of the flexibilities and social determinants of health provision in New York State and nationally as the world of healthcare integration has progressed. I'm happy to talk about more of these as we break out into breakout sessions, or you can email me. But we have been a long-term provider in the managed long-term care side of Medicaid here in New York State and are really grateful for that partnership with plans to serve their members who are too sick to shop or cook for themselves. We've done some really awesome work through some of the many acronymed programs made available by the ACA, but they're still not achieving the kind of equitable coverage that we want to see for the good of our clients. And so with that, I am going to pause my share and say thank you again to Natasha and team for holding this convening. I look forward to talking with you all in the breakout.
Great, thanks, Alyssa. And I think that's a great point that you mentioned, that despite the incredible results that you have and the long-term dedication to your program model, and that is why this meeting is happening today, because we want to work with all the stakeholder groups to come up with long-term sustainable funding for these programs that change lives. So thanks for mentioning that. We're just running a few minutes behind, so that means you don't get a stretch break. So feel free to stand up and take a stretch break if you need one. But I'm going to pass it over to Alex alum Eldine Meeks. Right here from the Food Pantries for the Capital District, we have a bit of a different approach because we are a coalition, so we have a network approach to our Food as Medicine program, and I'll have Alex talk a little bit more about that. Thanks.
Great, thanks, Natasha, and thank you to all the other panelists that chaired before me. It's even being involved in the process, it's great to hear it again and continue to learn. So I'm Alex. I'm the Special Initiatives Manager here at the Food Pantries for the Capital District, and I'm going to share a brief overview of how we run our Food as Medicine programming. Like Natasha said, we are a coalition of pantries. We have about 70 food pantries in our coalition in Albany, Rensselaer, Schenectady, and Saratoga counties. Throughout these counties, we work together to feed the hungry. That's our mission. At the food pantries, we support our members by providing funding opportunities. We help with purchasing, collecting, and delivering food. We provide opportunities for networking. We facilitate coordination of services, education, training for staff and volunteers, but mainly we work together to fill the gaps and share innovative ways to increase food security for all of our community members. In 2020, in the middle of a pandemic, we launched our Food as Medicine program. During its first year, we offered 3 service levels: tailored food pantry, healthy prepared meals, and healthy pantry plus. Each service level offered different dosage and frequency amounts. However, the goals were all the same. We'd hope that our program would address food security as a social determinant of health, to improve food access, to provide members with a uniquely enhanced experience, to maintain good nutrition and adequate food resources, and to provide fresh and healthy food choices. The picture on the right of this slide is an example of a tailored food pantry for a household of 1. Understand if we've met the goals of our program, we measured our outcomes 2 ways: through self-reported survey data and biometric data that our healthcare partners shared with us. We looked at ways that we could increase the patient's household security level so that they were no longer food insecure. We had a lofty goal of 100%. We looked at increasing patients' understanding of nutrition and portion size, increase consumption of healthy food, increase overall feeling of wellness, a decrease in A1C levels, a decrease in blood pressure, a reduction of BMI, reduced emergency visits, reduced ambulance use, and reduced hospital readmissions. As mentioned before, when we started our Food as Medicine program, there were 3 service levels. We currently focus on 2 with the hopes of changing our Pantry Plus model into a separate program offered to all of our coalition members. Our tailored food pantry service level serves low-income individuals who are food insecure and struggling with chronic health conditions such as diabetes, obesity, cancer, heart disease, or HIV and AIDS. Each household receives a weekly package of healthy food items to create 2 meals for 5 days out of the week. And we serve the entire household, not just the person being referred into the program. Healthy food items include whole grains, low sodium, low sugar, fresh fruits and vegetables, and oftentimes are specifically tailored to meet the needs of the individual's medical condition. Our healthy prepared meals service level is the other service level that we continue to utilize. This service level serves low-income individuals who are food insecure and struggling with health conditions, just as our tailored food pantry, but they also have the limited ability to perform their activities of daily living. They are more dependent. Each household receives a daily delivery of 3 meals a day, 7 days a week, and this is for 6 months. Just to look at some numbers for 2021, we served 417 households. 1,119 individuals made up those households. We served 92,789 meals, making up 4,035 food as medicine packages. Of those packages, 48 of them were medically tailored prepared meals. 2,775 were the medically tailored grocery packages. 1,219 were our Healthy Pantry Plus packages. About 89.5% of the food delivered to our participants required delivery. Lastly, I just wanted to go over what a participant's journey would look like. It all starts with our healthcare partners. If the individual is eligible for the program, the medical professional, dietitian, nurse, case manager, or health plan will refer them to us, the food pantries. They'll be connected with our resource line, and our referral specialists will conduct a pre-assessment with them. They'll go over some of those behavioral aspects, as well as kind of clarifying data around address and who lives in the household. The participant will then be connected to our food as medicine pantry. So as I said, there are about 70 member pantries in our coalition, but not all of them are food as medicine pantries. We make that referral using an internal software system called Oasis. The pantry then goes through their own intake process with the individual to start that relationship with the client being referred. The guests will either state that they need delivery, and if so, the pantry will offer that. If the pantry cannot offer the delivery, us, the food pantries, will step in and fill the gap. After the participant receives their food package and has access to all of this wonderful, fresh and healthy food, the hope is that they'll start to see an improvement in their health. Lastly, throughout the entire process, you'll see down at the bottom, they receive ongoing nutrition education in the form of live classes, pre-recorded modules, tip sheets, handouts, and recipes. And I will bounce it back to Natasha because I know that we are tight for time.
Thanks so much, Alex. So as you can see, we have a little bit of a different strategy since we are a network of providers. So I wasn't joking, we're skipping that stretch break. So just stand up and right here while you're at your desk. Alex is going to shift gears for us and give you just an introduction to the breakout room discussions. So what we'll do is she'll give you a little description. Then you're gonna go into the different breakout rooms. We have note takers in each room. They have questions and we have some pictures we'll show you for discussion. We'll come back. Alex will describe the second question, then we'll go back into the groups again. Then we'll come back and we'll wrap up our day. So Alex, I'm gonna let you do your magic.
Great, thanks. So before we head out into our breakout rooms, I am going to share something with you all. See 2 pyramids on your screen? Awesome. So we're going to take the next 15 minutes or so to discuss these pyramids. You'll each be assigned in a breakout room with a facilitator. We encourage you all to put your face back on the screen, have a discussion, get to know who's in your group. The left pyramid is a representation of the national model in regards to food as medicine. The right is a representation of Massachusetts state plan on what their pyramid of food as medicine programming would look like. The goal of this question is to see what works for New York State. One way is not right, one way is not wrong. We're really just taking the next 15 minutes or so to brainstorm and come up with what New York State should prioritize.
For anyone who got cut off talking, we're going to go back into the group so we can keep our conversations going. Alex,
Yes.
you want to set us up for the next discussion?
Yes. Pathways. So Katie presented earlier in our discussion together this slide and the following slide. And so your facilitator will take the time to bring them up on your screen and you will kind of go through the different pathways, pros and cons, and what stakeholders they best suit. So you will be in your same breakout rooms. I'm going to launch them and we'll see you in 15 minutes or so.
Thanks for teeing up those discussions. We're going to wrap this up in the next 10 minutes. So I want to thank you all. I hope you had some interesting discussions. These conversations will help inform our plan that we work on here in New York State. But we want to just take a minute to talk about the White House Conference on Hunger, Nutrition, and Health, and then talk about our New York State Community Food Assistance Network. And we would love for those of you who are interested and stakeholders to be involved in this process. So I'm going to just mention that we are putting a survey in the chat, and we will also follow up with an email that also has the survey that will help, again, provide some more input. And if you're interested in being an involved stakeholder through this process, please sign up the application for the New York State Community Food Assistance Network, and that will indicate to us. We'll reach out and we can chat more about how you can work with us on this process over the next year. I want to say, have any of you read the book, What the Heck Should I Cook by Mark Hyman? He talks a lot about federal policy. And so as our intro to our White House conference, Mark Hyman writes, our current federal food policies encourage big food to put private profit over public health. Despite the food system being the biggest national and global industry, over 1 trillion in the US and 18 trillion a year globally, we have no integrated, coordinated set of food policies. In fact, we have many agencies governing our food system and their goals are at odds with each other. And so I'm personally hoping that this conference will really help the federal government align their own agencies and policies with nutrition and health as a priority. And here at the Food Pantries and New York State Community Food Assistance Network, we are surveying our own coalition members to get input to inform the White House, and we've participated in a listening session. And I know Alyssa Wasung, you had some information that you were going to share about the White House conference as well.
Sure. Well, thank you, Natasha. So I've mentioned the Food is Medicine Coalition a couple times. God's Love leads it. I'm the policy committee chair. It's a collection of medically tailored food and nutrition service providers across the country. And we've been following this really historic conference. If you haven't heard about it or haven't heard about the 1115 waiver, I think we should put all of that stuff in the chat so people can do their own research. But the first White House conference was held over 50 years ago in 1969 and was a really seminal event that resulted in some of the major pieces of anti-hunger legislation that change lives in our country today: SNAP, WIC, school lunch, etc. Several really amazing advocates, including Congressman McGovern from Massachusetts, have been trying to get a second White House conference to happen for many years. And it was actually passed in the omnibus earlier this year, and it's going to happen in September. So what's different about this conference and what presents it as maybe a historic opportunity for us to talk about the connection between hunger, nutrition, and health is an increased focus on diet-related illness, the acknowledgement and fostering of an equity lens when we approach food, and a stated goal of lifting up the voices of people with lived experience, as we heard from Tammy, how powerful that witness is. And so we've heard also that the White House wants to concentrate on big, bold ideas, similar to like SNAP and WIC and things. So there's several ways that the White House has provided to give input directly. But then there are lots of other coalitions that are also offering platforms. One of the things as service providers that I think is difficult is that the timeline is extremely fast. I think everyone who has been led by Tufts and World Central Kitchen that's also collecting input and information. I put the website in the chat. They were gathering policy documents through June 15th. But I think along with other folks in the field recognize that there's kind of not a great way for clients and for people with lived experience to provide their input. So I'm going to post here some of the other areas that are being put forth as ways to gather client stories in a meaningful way. But I encourage you all to take part in the process. It's going to be really interesting to see what comes out of the White House conference. And it really is kind of a moment in history for food, nutrition, hunger, and health. So.
Great. Thank you so much, Alyssa. I really appreciate you mentioning the different opportunities and things that are happening for people's voices to be heard, to inform the plan that's going to be shared in September. So everybody is scrambling, but good thing there's some people out there organizing and coordinating these voices to share with the White House. So where do we go here in New York State? So I wanted to share that someone had asked, how do I get involved in the Albany area? Our survey, Alex put in the chat, it says form.jotform. That's the link to our survey for today's convening, but it also has the Community Food Assistance Network form, so we can get your information if you want to get more involved with this process here with us. Our next steps is to come away from this meeting. We had also done a food as medicine provider survey in conjunction with this meeting. So we're going to be looking at the current models in New York State. What are people doing with their models? What are the components? We're going to work with Emily and our friends at New York State to look at, the opportunities, the waiver, the in lieu of services. It's really important for all stakeholders to be involved in this process, from health insurance, hospital systems, community health, the food providers, the CBOs, dietitians, and the people who are participating, because we want to make sure that as we move forward with the system, it's something that works for everyone, so that no matter where you are in the state, your managed care organization, your health insurance company offers the opportunity for these valuable programs to be reimbursed, so that the participants can have access to these services. So we will be coming away compiling your thoughts and information shared through this meeting today, through the Food as Medicine Provider Survey. Over the summer, we're going to work on building a steering committee and come up with our action plan for where's the information that we still need to gather, what voices do we need to have at the table, what questions do we need answered, and move forward from there. So again, if you want to be an active participant in this process over the next year, please fill out the JOT form survey and give us your contact information. When we have a draft plan to share, we will invite everyone who participated in this meeting today, as well as the additional people who express interest to us. So if there are people that that weren't at the meeting today, please feel free to let us know or connect us here at the food pantries so that we can reach out. I'm going to put my email address in the chat. And again, we will follow up with everyone who participated today with the link to the survey as well. So if you didn't get it right now and you want to do it later, you'll get that along with the PowerPoints that were shared today. So again, I want to thank all of our speakers. I want to thank all of our facilitators. Alex, special shout out to Alex for organizing this today. You did a great job, and just thank you for everyone for taking your time and being a part of this. We're really excited about the potential and the opportunity to make a positive impact in so many people's health and support the organizations that are providing the services long-term, so that we can scale our programs and make them available to everyone who has a need for them in New York State. So again, thank you so much and enjoy the rest of your day. Thank you so much.
Hey, everyone.